Muy buenos días, soy el doctor Oscar Valencia, coordinador de este espacio de educación médica continua. Sean todos bienvenidos. Les recordamos que nos hagan favor de silenciar los micrófonos con el fin de poder escuchar mejor a nuestros ponentes. También les recordamos que recibiremos todas las preguntas a través del chat y al final las haremos llegar a los ponentes. Una encuesta de satisfacción que queremos que nos hagan favor de llenar. La liga va a estar en el chat y también está un código QR en donde también podrán tener acceso a esta encuesta. En nombre de la Escuela de Medicina y Ciencias de la Salud del Tecnológico de Monterrey, les doy la más cordial bienvenida a esta sesión académica de pediatría, en el que el día de hoy tendremos un tema muy interesante para el pediatra, el autismo. Es una enfermedad que tenemos que detectarla a tiempo y luego tener muy claro qué es lo que vamos a hacer para orientar a nuestros pacientes. Tenemos dos invitados especiales de Columbus, Ohio, la doctora Amy Newmayer y el doctor Juan Francisco Lozano, que me voy a permitir presentarlos. La doctora Amy Newmayer estudió medicina en Ohio State University College of Medicine. La especialidad de pediatría la hizo en Akron Children's Hospital en la misma ciudad de Akron, en Ohio. La subespecialidad en Neurodevelopment Disabilities en Kennedy Krieger Institute en Johns Hopkins Children's Center, que pertenece a la Escuela de Medicina de Johns Hopkins en Baltimore, Maryland. Ella es jefe interino y miembro de la facultad de la División de Development Behavior Pediatrics en Nationwide Children's Hospital en Columbus, Ohio, y está certificada en pediatría y en el manejo de discapacidades del neurodesarrollo. El doctor Juan Francisco Lozano estudió medicina en la Escuela de Medicina y Ciencias de la Salud del Tecnológico de Monterrey. Nos honra tener un exalumno aquí en esta sesión. La especialidad de pediatría la realizó en el Children's Hospital Michigan en Detroit, Michigan, y hizo una maestría en investigación clínica y administración regulatoria en Northwestern University en Illinois. Se encuentra actualmente cursando la subespecialidad en Development Behavior Pediatrics en Nationwide Children's Hospital en Columbus, Ohio. Está en uno de los hospitales reconocidos como de los mejores en Estados Unidos en la atención pediátrica. Está certificado en pediatría el doctor Juan Francisco Lozano y también en investigación clínica y en el manejo de discapacidad de neurodesarrollo. On behalf of the Escuela de Medicina y Ciencias de la Salud del Tecnológico de Monterrey, you are most welcome, Dr. Newmayer and Dr. Lozano. Without further ado, I shall give you the floor. Thank you for being with us.
Thank you.
Muchas gracias. Entonces, bueno, muchísimas gracias a todos en lo que la doctora Newmayer está compartiendo la pantalla por esta invitación y es un honor estar presentando ante ustedes, como dijo muy bien el doctor Valencia, como un exalumno y ahora estar con ustedes. Entonces, el día de hoy vamos a estar hablando sobre los trastornos del espectro autista, cómo sospechar y cuáles son los siguientes pasos. Dr. Newmayer, next, please. Dentro de los objetivos que vamos a estar hablando el día de hoy es, next please, thank you, reconocer las señales tempranas en el diagnóstico del espectro autista, reconocer cuáles son las señales, también las herramientas necesarias para hacer un tamizaje, el proceso diagnóstico, las comorbilidades que podemos ver en pacientes y las intervenciones recomendadas para todos los niños que estamos viendo con una sospecha de autismo. Next, please. Entonces, cuando estamos viendo un trastorno del espectro autista, tenemos que ver un poco sobre cuál es la prevalencia y la historia detrás de ello. Next, please. Entonces, en el trastorno del espectro autista, reconocer que es una etiología heterogénea. Entonces, hay muchos factores involucrados en un trastorno del neurodesarrollo, como típicamente vemos en muchos de los pacientes que vemos. A nivel mundial, afecta del 1 al 2% de la población. En Estados Unidos he dicho que 1 en 18, 1 en 15, 1 en 54, y esto es 18 de cada 1000 niños están afectados con un trastorno del espectro autista. Y bueno, varía la población en la que estamos estudiando. Y en México, aunque no hay muchos estudios, solamente hay uno, se calcula que 1 en 115 de ellos están afectados por un trastorno del espectro autista. Cuando vemos la historia del autismo, está toda esa creencia en que es algo que es nuevo o que está teniendo, como le decimos, un hot topic, entonces estamos hablando mucho sobre ello. Pero si nos vamos atrás en el tiempo, vemos que ha habido históricamente descripciones de individuos con trastorno del espectro autista. Entonces, en los 1700, en edad temprana, Hugh Blair se describió claramente. Dr. Newmayer, please go back to the previous one. Thank you. Antes de 1800, el niño salvaje de Aveyron también se describió como lo que típicamente es actualmente un trastorno del espectro autista. No fue hasta 1911 que se acuñó el término de autismo, pero para describir a los pacientes con esquizofrenia. En 1943, Leo Karner, un psiquiatra austriaco en Johns Hopkins, hizo la primera descripción de niños con dificultades afectivas y de comunicación, interesantemente describiendo más niños, 8 de los 11 eran varones. Al mismo tiempo, Hans Asperger describió en el otro lado del mundo el síndrome de Asperger, en el que eran niños con inteligencia no verbal más alta, pero aún con dificultades de socialización, pero su investigación no se hizo tan abierta y fue hasta 1981 que la psiquiatra inglesa, la doctora Wing, dispersó toda su investigación y bueno, la historia en cuanto a de dónde sale este término. Entonces, esto es donde apareció y es importante, next please, ver cuál es su evolución diagnóstica a cómo aparecieron estos términos. Entonces, en las primeras ediciones del DSM, el manual diagnóstico que utilizamos para dar diagnósticos de salud mental, del neurodesarrollo, el primero en 1952, realmente autismo no era parte de él. Se utilizaba, como dijimos inicialmente, como parte de la esquizofrenia. No fue hasta el DSM-3 en 1980 que aparece la primera descripción y criterio diagnóstico de autismo infantil, y tuvimos la evolución con cada revisión. Interesantemente, en el DSM-4 cambió de ser un desorden de autismo, autismo infantil, a tener las categorías que ahorita mucha gente está muy familiarizada y acuñó muchos de esos términos a su práctica social, y tenemos el síndrome de Asperger, Rett, y esto evolucionó otra vez en el DSM-5 a regresar a un trastorno del espectro autista. Entonces, un término muy global. Next, please. Cuando vemos los criterios diagnósticos actuales de un trastorno del espectro autista, estamos viendo dos áreas esenciales. Uno son las deficiencias persistentes en la comunicación e interacción social. Y aquí tenemos que tener los 3 síntomas para poder llegar a un diagnóstico. Entonces, uno es la reciprocidad social. Entonces, es cómo se acerca, cómo inicia conversaciones o cómo inicia una interacción social. Deficiencias en las conductas de comunicación no verbal. Entonces, es toda esa integración verbal y no verbal, que utilizamos el uso de gestos, de manos, entender lo que el otro está diciendo, y luego desarrollar y mantener relaciones, y aquí estamos viendo cómo se ajusta con diferentes contextos sociales, el juego imaginativo, el juego con otras personas y el interés en ellos. Y luego evaluamos los comportamientos repetitivos, restringidos, y aquí nomás necesitamos 2 de ellos, y es las estereotipas o movimientos repetitivos, que muy frecuentemente vemos como el aleteo de manos, ecolalia, pero luego hay otros puntos como las frases idiosincráticas, la insistencia. Entonces, estos son niños que tienen problemas con transiciones, son muy rígidos en sus comportamientos, y de ahí se originan muchos de esos problemas conductuales. Tener intereses muy restringidos o fijados en ciertos temas. Y luego la parte sensorial. Entonces, que tienen dificultades con ciertas texturas, olores, temperaturas, o que están muy interesados en ciertas características sensoriales. Estos son a grandes rasgos y los vamos a ir viendo a través de la sesión. Next, please. Entonces, viendo la prevalencia, como decíamos anteriormente, se ha visto que hay una prevalencia mundial, depende de la comunidad que estamos evaluando, pero específicamente de Estados Unidos, que es un sistema que evalúa y sí, tiene un seguimiento, se ha visto un aumento. Y actualmente estamos hablando de casi 18 de cada 1000 niños que tienen un trastorno del espectro autista. Y parte de eso ha sido esa evolución de criterios diagnósticos que ha llevado a esto, pero también hay otros factores que otra vez vamos a estar viendo a través de la sesión. Next, please. Y parte de esta evaluación, estamos viendo cuál es el seguimiento que tienen estos niños desde las primeras sospechas a cuando hacen una evaluación diagnóstica. Y uno de esos empujes ha sido llegar a un diagnóstico más temprano y eso es por medio de esa educación continua. Y se ha visto que muchos de estos sitios que se evalúan están teniendo llevando a que antes de los 3 años están teniendo una evaluación. Entonces se ha visto esa mejoría diagnóstica. Next, please. Entonces ahora now Dr. Newmayer will take over for the session. So go ahead, Dr. Newmayer.
Hello. So one of the things that we wanted to talk about today are some of the early signs of autism spectrum disorder and the initial screening that occurs for autism. This study, they looked at children who had screening with the MCHAT, which is one of the screens that we use for signs of autism spectrum disorder, and then went back and looked at the final diagnosis between which children had autism spectrum disorder and which did not. And they did find some differences in those presentations. So the speech area was one that was more likely to be a concern for children who had that final diagnosis of autism spectrum disorder. They were more likely to have repetitive behaviors and reports of difficulty with social interaction. And then also some concerns about behavior temperament that was actually higher in the non-autism spectrum disorder group, and then also medical problems were lower in the non-autism spectrum disorder group. And what these concerns are, they nicely broke down into this table, and these are some common concerns that parents may present with for either a well-child visit or sometimes during other visits. So concerns about talking, so he likes to spin in circles, might be a repetitive behavior, doesn't like playing with other children, might be a social concern, eye contact, and then sometimes children with autism spectrum disorder actually present with a non-specific concern, so something that may not be directly related to those DSM-5 criteria, but concern about behavior, concern about delayed potty training, a concern about feeding and eating concerns, and sometimes just general specific, non-specific concerns that parents have about children not reaching their milestones on time. And so I'm going to, hopefully we'll get our YouTube video to play. So this video is from Kennedy Krieger Institute, and it shows nicely some of those early signs of autism spectrum disorder and what that might look like when you're seeing children.
Here, he imitates the lady's action with the pretend lipstick.
So this part is a child with typical development.
This helps him to learn new play skills and at the same time synchronize his actions with the actions of others.
Yeah, she has lipstick on. Oh, just like mommy wears.
Okay. And then this
This 19-month-old child shows signs of ASD. He has an intense interest in the toy phone.
Toys R Us is
He does not share his enjoyment of the phone with others.
set up like the classroom.
He does not look toward others and smile.
Shelves, sensory, all kinds. He really has this addiction to telephones lately, though. It's okay though, because it's helping him to make sounds. So there's probably like 10 telephones laying around my house because he walks around carrying them and sits them down, and then he goes on to the next one.
Although he puts the phone to his ear, he does not show creative play with the phone. When his name is called, he does not respond.
Elliot. Ellie. Ellie. Elliot.
He does not offer the phone to others so that they can have a turn.
He would turn to his name, and progressively he's not.
His mother
Okay, Dr. Lozano says it's not coming through really well on the feed. So what we can do is make sure that people have that link later. If you want to go back and watch those YouTube videos, there's 3 different short vignettes of early signs of autism spectrum disorder. And they also have some typically developing peers the same age. So it's a nice to be able to contrast those skills. So going on to developmental screening, if parents come in with one of those concerns about the child's speech or their development, kind of what is that next step? And so this is a vignette that we have. So Lucas is a 24-month-old boy who comes in for his well child check. He has been growing well. You don't identify any medical concerns. His mother asked for guidance regarding tantrums, which are occurring daily, happening in multiple settings. The grandmother told her that that's okay and that he's just now hitting the terrible 2s in terms of behavior. And so one of the questions is this expected and typical for development, or could this be an early sign of autism spectrum disorder? So thinking how to respond in that moment, one of the things that's really key is just being able to listen to the family's concerns, so getting a little more information about those tantrums, kind of what context they're occurring in. And then the second thing is to be able to administer developmental screening, which is standardized. And that can help you determine those parents' responses and whether they're different than responses of other parents of 2-year-olds, or whether that's more typical behavior. So the recommendations from the American Academy of Pediatrics is to implement screening in all general pediatric practices. We recommend broadband developmental screening at ages 9, 18, and 30 months. And then also at 4 or 5 years if there are concerns for school readiness. It's also recommended that autism-specific screening be done at 18 and 24 months, and they generally recommend using the MChat. There are a few other screens that can also be used for autism, but they're less common than the MChat. And then developmental surveillance should occur at all well child visits. So screening is when we're using those standardized assessments, but surveillance is asking parents questions about the child's development, and the parent may bring up these concerns and then exploring those more readily. So some commonly used developmental screening tools are the Ages and Stages questionnaire, the Parent Evaluation of Developmental Status, Patel Developmental Inventory, and the Brigant screens. All of these have a literacy level of 5th grade. These all that I chose are available in both English and Spanish, and they take about 10 to 15 minutes to administer for the parent. And it's what I usually will talk about is that really any of these questionnaires is fine to use depending on what works for your practice. The biggest thing is using something that's standardized, as studies show us that if we use just those general surveillance questions alone and not a standardized questionnaire, that we can miss a fair number of children who may have developmental delays. So this is another study that just shows parents' experiences with bringing up concerns about their child's development. And if we look here, the mean age is around 2. There's autism overall, and then they've divided that into autism spectrum disorder with coexisting developmental or intellectual delays, and then autism only without developmental delay, and then developmental delay only. But what this table shows us is that parents are usually bringing up a concern about age 2. For children who are diagnosed with autism spectrum disorder, their mean age of diagnosis is not until around 5 to 6. And that translates into a gap of about 2.5 to 3 years between first concern and when the child actually is diagnosed. And as Dr. Lozano showed with the previous slides, we're really trying to get that age of diagnosis down closer to that time that parents have concerns. One of the things that helps with that is thinking about how we respond as providers to parents' concerns about their child's development. So the first section here is what we call proactive responses. So those are suggesting that the parent discuss concerns with the school, conducting those standardized developmental screens, making a referral to a pediatric specialist. Then they broke those down into whether there was no response or 1, 2, or all 3 of those. And what we see is that really translates into a younger age of diagnosis. Conversely, if we look at just reassuring or passive responses, so this is reassuring the parent that the child may grow out of it, or maybe saying, you know, we'll wait a little longer and see how they do with their development, we see that that's actually associated with a later age of diagnosis. So it's very important to think about reassurance is important a lot of times for families, but also taking those proactive steps to go ahead with additional screening or referral if there are concerns about development. So we also want to talk about autism spectrum disorder diagnostic evaluations and what those components are. And so there's various components of evaluation. The first is history. So again, that is where we are looking for those DSM-5 criteria about the child's social communication, any repetitive behaviors they may have. Also important to standardize our assessments for autism spectrum disorder. And so there's various assessments that we can do. The ADOS is still considered the gold standard test. And that is a structured observation, again, for those DSM-5 criteria. And the components of the video earlier, if you watch that, have components of the ADOS in as well. So similar skills that are being assessed. There's also the CARS, which is something that the provider can fill out, doing a structured observation of the child. There's also the autism diagnostic interview, which we've been using with our telehealth visits, since it's hard to administer those more direct assessments right now while we're doing more telehealth. So there's a variety of different standardized instruments that are available. We always want to look at where the child's developmental and cognitive level is, as that will tell us a little bit more about what we would expect for the child's development and social skills based on where they are currently functioning. For examination, we're looking for dysmorphic features that might suggest a genetic diagnosis, neurocutaneous signs, so the child have cafe au lait spots, and their general growth. And we'll talk a little bit more about genetic testing here in a moment. So what are risk factors that we know that we can look for in history for autism spectrum disorder? Paternal age is associated with a higher risk for autism spectrum disorder, with a 1.3-fold increase for every 10 years of paternal age. Twin gestation, identical twins, the others affected, there's a wide range here based on the study. So it can be from roughly 1/3 to almost 100% of the time. Non-identical twins, studies are showing 0 to 31%. Once parents have one child with autism spectrum disorder, the risk goes up for subsequent children having autism spectrum disorder. family genetic conditions that are known that the child may have inherited, early changes such as prematurity, low birth weight, fetal growth restriction, and then for maternal factors, we can see advanced age, gestational diabetes, various in utero exposures, or congenital infections can all confer a risk for autism. Vaccines is something that comes up a lot of times when we're talking to families. Still much of a concern. There's a lot of information out in the general media about vaccines. The initial concern was about thiomarisol, which vaccines have not contained since 2001. There's been many, many studies done to look at possible relationship of vaccines and autism spectrum disorder. And there's no evidence of any influence of vaccines, particularly the MMR is the one that's been most associated. And even for patients with autism spectrum disorder who might have siblings who are increased risk, there's no influence of MMR vaccine. So getting back to why we might want to look for genetic conditions, it can help us improve how we're talking to families. Families can learn more about prognosis and what to expect in the future. They can learn more about recurrence risk for autism spectrum disorder in future children. Some families, it's very important for them to just know that cause of autism spectrum disorder, and so that can improve family knowledge, empowerment, help them understand what steps they need to take. And sometimes it will help refine our treatment options, and it helps with acquiring needed services. It may help us avoid additional genetic tests or to other diagnostic tests that aren't needed, such as MRI. So what are some common genetic conditions that we see with autism spectrum disorder? We can see single gene disorders such as Fragile X syndrome, Williams syndrome, Rett syndrome, neurofibromatosis, or tuberous sclerosis. There are also some copy number variants that are very common with autism spectrum disorder listed here, and then sometimes there's single nucleotide variations as well. So can we talk a little bit about recurrence risk? Generally, recurrence risk we will say is around 10%. If it is the first child with autism spectrum disorder, if families have 2 children, that continues to increase. And even if the subsequent children do not develop autism spectrum disorder, they have a higher risk for other developmental conditions such as delayed language and other psychiatric disorders. Wanted to transition and talk a bit about what are some of the medical conditions that we look for when we're seeing children with autism spectrum disorder. And one of those that commonly comes up is seizures. So EEG is not recommended as a routine evaluation test for autism spectrum disorder, but because seizures are more common, we will kind of take a closer look on history. If there's history of staring spells or other seizure-like episodes, then we will request EEG. We can also see GI symptoms are more common, so that can be abdominal pain, diarrhea, constipation, and reflux. There are feeding issues. So a lot of children are very selective eaters, which can be based on different factors such as texture or color of food. And they can also have delayed oromotor skills with chewing and swallowing. Obesity is more common for the children that we see, sometimes because they have less access to activities such as being in with a team sports. Dental visits can be very hard for the children that we see, so they can sometimes go without dental care. And then we can see pica, and that can be associated with low iron stores or a high lead level. Sleep is a very common problem that we see also. So about 50 to 80% of children with autism spectrum disorder will have sleep onset problems or insomnia. This can persist all the way to adolescence. Sometimes children will have delayed sleep onset. Sometimes sleep maintenance is also a concern. And then motor disorders of coordination, tic disorders, and catatonia can also occur. Behavioral health issues are also common for children with autism spectrum disorder. So associated psychiatric conditions occur about 70 to 90% of the time. Most common are ADHD, anxiety, depression, obsessive compulsive disorder, and other disruptive behaviors. And these can really affect everyday functioning for children, sometimes more so than the autism spectrum disorder diagnosis itself. So some of the interventions that we have can really help children with autism spectrum disorder develop those social skills and communication skills. We have various goals when we consider interventions for autism spectrum disorder. One of the first goals is we want to minimize those deficits. We want to maximize children's independence, and we want to minimize or prevent some of those problem behaviors such as aggression. Some of the studies show us that long-term behavior can be a big component of how independent children are able to be, for instance, with job skills or other areas. And so it's a big area that we like to focus on even when children are younger. And we can divide those types of interventions into educational interventions, developmental interventions, and behavioral interventions. And so the most evidence-based approach that we have for treatment of autism spectrum disorder is applied behavior analysis, or ABA therapy. These interventions are based on learning theory, and the goal is to target development of new skills, minimize behaviors that interfere with progress. ABA therapy can really occur a variety of ways. So the most traditional LUVAS method is about 40 hours a week. Commonly for us, we can see children more commonly in a 10 to 20 hour a week. Some children will receive ABA as part of being in a specialized school, and that will also kind of be built within their school day. There's also some other interventions that are relatively common that try to use a naturalistic approach. So the Early Start Denver model kind of incorporates components of ABA along with general developmental principles. Educationally, we like to make sure that children are in the least restrictive educational environment. And so in the past, children who had special needs may have been pulled out and been in a totally separate school in a separate building and not really exposed to their same age peers. And now we've learned that there's a lot that children can learn by being more integrated. And so we're always looking at how much they can be integrated and still have the appropriate supports that they need. So some specific classroom-based interventions that you may hear about, one is the LEAP program, and that stands for Learning Experiences and Alternative Programs for Preschoolers and Their Parents. Again, this combines some special education services along with ABA approach, and they focus on that inclusion setting as much as possible, and focus for elementary school grades. Teach or treatment education of autistic and related communications for handicapped children approach is again a classroom-based approach, emphasizing structure, visual schedules, and just general organization of the learning environment to support children. And then the last area is social skills instruction. So for older children who may have milder forms of autism spectrum disorder, social skills interventions can be very helpful for children to help focus on building those language skills and able to have conversations with peers. Speech and language therapy is also a huge component of interventions that we provide for children. Sometimes that's focused on those main components of speech, either articulation, receptive or expressive language. For children who have delayed language, we are sometimes introducing augmentative communication approaches. One of the questions that we commonly get from parents is, the concern that using sign language or using a speech generating device will affect the child's development. But again, the research shows us that that doesn't hold up the verbal skills for children, and in fact may enhance their verbal skills as they learn to combine sign with speech or combine using the augmentative device with their developing speech. Motor skills, again, as we talked before, we can see low tone commonly or coordination issues. And so for those children, we may refer them to occupational therapy or physical therapy. Another intervention that's common is sensory interventions. There's some very modest evidence for sensory issue. It's not generally supported yet by peer-reviewed literature, but some families do report finding those interventions helpful in the home setting. There's some interventions that are not supported by evidence, again, that we will hear about commonly. So one of those is a gluten-free, casein-free diet, and then various vitamin supplements. Again, for these interventions, what I look for when parents ask about these, one is whether we have evidence of them. And the second is if we don't have evidence, could these interventions potentially be harmful to the child? And so for the gluten casein-free diet, if parents want to try that, it's generally not harmful. We have to make sure that they're getting other vitamin D and calcium sources. And we also recommend that they see a nutritionist so families know how to continue to balance that diet with those limitations. Again, supplements, most of these would not be considered harmful, but we just don't know for sure that they're helpful. And the same is true for auditory integration, horseback riding therapy, and vision therapy. Where we start to get more concerned about potential harms is trying immunotherapies, daily antibiotics, daily antifungals, as those can have side effects. Chelation therapy can have side effects. That was more common probably about 10 years ago. We're seeing that a little less often now, but there can be also harmful effects of medicines used for chelation therapy and hyperbaric oxygen. Can also be harmful. And so generally for those, we don't recommend those because of the concern for harm. And usually would actively counsel families not to pursue, again, those medications, chelation or hyperbaric oxygen. Another thing that I also will talk to families about is that money is also a bit of a side effect of these therapies. And so if parents have a limited amount of funding, which most do, then we would rather have them put that towards ABA or a therapy that we know is going to help versus, let's say, auditory integration therapy or vision therapy or something that may not be as helpful. Some of the challenging behaviors that we see, again, are related to those comorbid DSM-5 diagnoses. So we can see hyperactivity, impulsivity, poor attention span, anxiety. Sometimes repetitive behaviors can be problematic and challenging, or self-injurious behavior. How do we approach those? So the first thing is to do a careful assessment of those behaviors and try to figure out when they're occurring, what things might be triggering them, what the response has been to past interventions that parents have tried. We try to get input from multiple sources, so that's most typically home and school. Use of standardized behavioral scales can help us in this regard, so that we can follow over time and see what the response is to the interventions that we're trying. And then also assessing what are those existing available behavior supports for families within the community. So that could be school programming, family support, or other behavioral services. There's also common for us to look for medical factors that might be causing or exacerbating those symptoms. So for some of our patients, particularly those who have limited communication, they may be having pain. For instance, a lot of children have constipation. They may be having abdominal pain that may end up triggering some irritability and disruptive behavior. Sleep problems, again, sometimes can then contribute to the behavioral issues that we're seeing. So we try to identify and search for those and address those. Sometimes if we've tried those behavioral approaches and we're not seeing response, and we do consider medication if the symptoms cause significant impairment. And then we choose medications based on what those target symptoms are, also practical considerations of costs, side effects, and monitoring. And there's not one single medication for those core symptoms of autism, and so we are really treating those comorbid conditions with medication. And then finally, one of the other things that we want to touch on is it's very important to think about medical home concept for children with autism spectrum disorder. And those children do have considered to have special health care needs. And an identified medical home can assist families with coordinating services for school, different developmental interventions, necessary medical interventions, helping family connect with community supports. One of the things that's very helpful for families is to connect with other families of children who have autism spectrum disorder. We know from the literature that there's a higher overall level of stress when families have a child with special health care needs, and particularly autism spectrum disorder. And they also may feel less connected to the community. So those problem behaviors that children have may keep them from being as interactive in the community as other families. And some of the things that we like to look at for medical home, we like to say that it needs to be accessible, comprehensive, family-centered, coordinated, and compassionate. So those are things that we like to think of. And there's some data to suggest that medical home actually can help reduce overall costs. So in addition to helping families coordinate, helping address some of that stress that they may have and helping to care for their child. This study, they looked at the measures of success, satisfaction of care, and family impact among children who had autism spectrum disorder. Children had special healthcare needs with other emotional, developmental, and behavioral conditions other than autism, and then other special healthcare needs. So that could be something like diabetes. What we can see is that the presence of autism is more likely to be associated with unmet needs for special healthcare services, more likely to be associated with unmet need for family support services. A lot of these children have difficulty receiving services. The families report a high level of financial implications, particularly for autism spectrum disorder. It's very common for families to have to reduce or stop their employment due to their child's condition. So it's 57% of families said that they'd had to change their work hours. Behavioral issues also had the similar effect, although less so, and then other special healthcare needs still had that effect, but much less than we see when children have different behavioral conditions. And then also just the amount of time that families are spending providing care to their child. So more than 10 hours a week just for care, coordinating care, and then high out-of-pocket expenses for medical care is also common. And then this slide is related to the same study. And what it shows is that when children have a medical home, that really addresses some of those core concerns. So when we look at financial problems for the family, we look at children with special healthcare needs with autism spectrum disorder without a medical home. 44% of families said that that was concerning. But then that goes down to 22% if they have a medical home. And we kind of see that same for decrease for needing extra income, decrease in needing to stop employment, and then some decrease in the financial costs as well. So medical home model can be really helpful for these families and affect their long-term care. So some take-home points. Autism spectrum disorder is complex. It's heterogeneous. Neurodevelopmental disorder. So as we often say, if you've met one child with autism spectrum disorder, you've met one child with autism spectrum disorder. So while it's one overarching diagnosis, what that looks like for each child can be quite different across the autism spectrum. There can also be various different causes for autism spectrum disorder. So sometimes we're able to identify a genetic cause, sometimes or not. Sometimes it's associated with other conditions, such as cerebral palsy or intellectual disability. Diagnosis for autism spectrum disorder really requires a thorough evaluation process. So there's expert opinion on assessing core symptoms, which is your history and really looking for those DSM-5 criteria, and also recommended to do some standardized testing, such as the ADOS or the CARS or other available instruments. And then establishment of a medical home and being able to serve as a medical home for these families really helps improve family rapport, decreases their stress, and improves adherence to the interventions that we do recommend. So Temple Grandin is an adult who spends a lot of time educating people about autism spectrum disorder, and one of the things that she says is that I am different, not less. And so again, the children with autism spectrum disorder do have differences with their social communication development, but they also have a lot of potential, and our goal is to, again, help kids be as functional as possible as they get older. So we have some time for questions if people wanted to submit.
All right, so I've been receiving some of those questions, Dr. Newmayer.
Okay, great.
So I'll start asking you the questions. So one question is, what would you recommend approaching a family to, and the parents, to give them hope in front of a new diagnosis?
Yes, that is a great question. I'm glad someone submitted that. So I think again, getting that autism diagnosis can be really overwhelming for families. Families worry about their child's future, what that's going to look like, what things are going to be like for them as an adult. I think there's a lot of hope. We know more than we used to know about autism spectrum disorder. Our treatments are improving. And so particularly, again, thinking about that age of intervention, the younger we start with interventions, the better children's outcomes are. And so that's something I talk to families about, the more we can do when they're younger. I have learned over the years not to give a really detailed prognosis to families, because when we're seeing kids at 2 or 3, kids can really surprise us. So we might have a sense of, is this going to be a lifelong problem for the child? But some children really respond well. And so it's really a matter of following over time. And that's where that medical home piece comes in for families. But it is definitely, a time for families where it does kind of change, the thoughts and expectations that they have for their child. I think that's the other place where also connecting them with other families can be helpful. So if you know other families within your practice that have children with autism spectrum disorder that would, be able to serve as mentors to families, that can be really helpful, especially with that initial diagnosis.
Perfect. Now, looking to diagnosis, so genetic testing, what do you usually recommend, or first steps?
Yeah. So our first steps for genetic testing now, we test for Fragile X syndrome, and we do a microarray. For children who have dysmorphic features, the karyotype actually may have a higher yield than the microarray, but without dysmorphic features, which is most of the children, then would be microarray. And then again, based on the physical examination or history, if there's specific genetic conditions you're concerned about, then we can test for those individually as well. So sometimes for girls who may have developmental delay and regression, we may also do Rett syndrome testing with MECP2 gene.
Perfect. Next question is your thoughts about relationship between diet and autism.
Okay, yeah, so that's common. We touched on that just a tad with the gluten-free, casein-free diet. A lot of the concerns for diet are related back actually to some of the concerns with the vaccination. So there's some thought that the MMR vaccine can also cause this, there's kind of this brain-gut connection. And again, there's no definite research that we have that supports that. Some parents do report to us that they feel the dietary changes help. It's not clear why. So one reason might be like if you're eliminating milk from the diet, if the child had lactose intolerance, they may have less GI distress if, you know, we've taken milk out of their diet. So it could be other reasons for that other than that typical theory about brain-gut connection. Having said that, I think it's something that parents often want to try. And again, as long as we're keeping that diet balanced, I think it's fine. And if they notice a change, then they can stay on it. I tell parents, if you've tried it for a few months and you don't notice a change, you know, not to feel like you need to stay on that diet. It can be more difficult, you know, particularly families that have other kids. Pretty much the whole family has to be on the diet, and the foods can be more expensive to buy and prepare. So those are all things to consider for families as well.
Another question is, how convenient is for kids to assist a specialized school?
So how common for children to go to a specialized school?
Is it how convenient it is for them to attend a specialized school?
Okay. So I think that probably varies, you know, based on where you live. So like here in Ohio, the school parents are able to use their special education funding through the school district to attend school. So we have a number of different private schools for autism spectrum disorder. The availability changes in even different parts of the US or different countries. Some of the advantages are that integrated therapy and ABA. So for children who are responding well to ABA or need a lot of one-on-one help, being in that specialized school program can be very helpful for them. The converse side of that, again, is not having as much exposure to their same age peers that are typically developing. And so that's always the balance that we try to maintain. If that is the case, we can think of other activities for kids in the community that they might be able to have that interaction with typically developing peers. So their sports programs or other things in the community can be helpful.
A question is, what would be your standpoint on recent studies regarding autism in girls and not being diagnosed until older?
Okay, that is a great question too, so I'm glad that came up. So yeah, autism, typically we talk about 3 to 4 to 1 of a male to female ratio of diagnosis. There's been a lot more focus just in, I would say, at least the last 5 to 10 years on girls. Girls tend to end up being diagnosed a bit later. They tend to have a little less of some of the repetitive behaviors or things that may bring kids to attention a little earlier. And so the thought is that we may have been missing some girls all along. Also, one of the studies that's really fascinating was a functional MRI study that was done. So they were looking at some of those social skills tasks within the functional MRI. And they found differences for boys with autism spectrum disorder. Girls with autism spectrum disorder, their brains looked more like typically developing boys, and then the girls with typical development look different. So there's like these different groups. And so again, I think the symptoms may present a little milder in girls and look a little different is the thought. But I think there's going to be a lot more research coming out on that in the future, which is great.
Diagnostically wise, what is the minimal age when you can diagnose a kid with autism?
Okay, so most typically kids are getting picked up around with those screens at 18 to 24 months. I've had a few siblings, so we had already that kind of high index of suspicion because they had an older sibling with autism spectrum disorder. Some of those parents have come in around 12 to 15 months. Typically, you will have to think about like that 12 to 18 month level cognitively. So some of the skills that we're assessing on the ADOS, typically if children's development is below that level, then it's hard to actually make that diagnosis based on those skills. So children may not be showing some imitative and pretend play yet, just because their overall development is not at that age level. So for that reason, there's still probably in that 12 to 18 month range would be the youngest. age, again, there's more research people are doing and trying to look at really early signs like early eye contact. And so over time, we may have better tests that can detect things at a younger age, but based on our current gold standard tests, those have a limit with the developmental level of the child.
Another question is your thoughts about use of specific medications like piracetam or levocarnitin for any autism and other developmental disabilities.
Mm-hmm. Yeah, so we don't use those commonly. Again, there's more interest in those, like the carnitine. Sometimes children will be on those supplements if they have low tone, but again, not things that we're using commonly yet. I think one of the things that I always like to mention too is because we don't have, you know, a definite cure for autism spectrum disorder in a way, I think there's a lot of interest in kind of anything that can help. That interest is across the medical community as well as that parent community of just trying to think of what are the things that we could do that might be helpful for these children. So I think a lot of things do come up and may be helpful in specific cases depending on that child's, you know, specific presentation or medical history.
Okay. All right. So I think those covered a lot of the questions. Some were repeated. So,
okay.
Yeah. Dr. Valencia, any other questions back there? All right. Okay.
Well, thank you very much, Dr. Newmayer and Dr. Lozano for your excellent presentation. And we thank you for sharing your knowledge and your experience with us. And it's we'll see you soon in another session. Thank you very much for being with us. Okay.
Thank you for having us. It's great to be able to connect like this. So thank you.
Thank you. Have a good day.
Igualmente, muchísimas gracias. Bye bye.
Y muchísimas gracias a todos los que se conectaron en esta sesión. Muchas gracias.
Soy la voz que te habla desde dentro. La primera vez que me escuchaste, no me pudiste ignorar. Y dudaste. ¿De dónde viene? ¿De la cabeza? ¿Del estómago? ¿Del corazón? Primero te inquietaba. Después te di claridad. Porque tus caminos son la salud, la ciencia y el conocimiento, que te preparan para ayudar, sanar y salvar, para hacer una diferencia. Hoy sigo aquí, en medio de esta tormenta sin precedentes, empujándote a hacer historia con cada vida que tocas. Y cuando preguntes, ¿por qué yo? ¿Por qué ahora? Yo te hablaré más fuerte, recordándote que una comunidad de profesores, estudiantes, colegas y profesionales de la salud te respalda, y reafirmándote que has elegido bien, que estás donde tienes que estar, haciendo lo que tienes que hacer. Soy la voz que te habla desde adentro, tu intuición, tu llamado, tu vocación.